Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. If this is the first time you're watching one of my procedures, please do feel free to like, comment, share the video. If you're watching on YouTube, you can also subscribe and select the bell icon so you'll get notified as and when I upload new videos. And similarly, if you're watching on Facebook or Instagram, please do follow the page. So this procedure is all for the people who really enjoy skin peels. This is a patient who attends regularly to have his ears cleaned. He's got a bit of otitis externa in both ears. So otitis externa is actually an umbrella term for an infection and or inflammation of the outer ear canal. The patient here, you can see this keratin, this dead skin that's died, shedded but not migrated. And in the right ear, this is the right ear, this dead keratin has actually create a sheet that's completely occluding the ear canal and obstructing the view of the eardrum. You can see we just peeled that off and the eardrum's now visible. The patient wears hearing aids as well, and when you've got a blocked ear, whether it be due to earwax or dead keratin in this case, the sound that's amplified into the ear by the hearing aid hits the wax or the dead skin and it reflects back out of the ear canal, and that amplified sound that has been reflected back out of the ear re-enters the hearing aid microphone. Therefore the hearing aid re-amplifies the same sound, and once again that re-amplified sound enters the ear, hits the wax, hits the dead skin, reflects, bounces back out of the ear and re-enters the microphone again. And you have what we call a feedback loop, and that causes the hearing aid to squeal and whistle. And in fact, when the patient arrived, I could hear the whistling from outside the clinic door. It was that bad, and so the patient's wife wasn't very happy, and she said, "You must go today and get this sorted." So I've removed the main blockage. You can see the whole eardrum, it's fully intact, fully visible, nice and healthy, and I've removed that sheet, that film of dead skin, dead keratin. So I'm just mopping up near the entrance now. With this patient, I just want to remove as much dead skin, wax, keratin as humanly possible. We can't always remove every little last speck because it can be uncomfortable for the patient. And we only really remove dead keratin when there's a clinical need. So for this patient, because the patient attends regularly with the same problem and it affects his hearing aid, for me that is, where possible, to remove as much dead skin as I can is important for this patient. Another occasion where I tend to remove dead skin that's lining the ear canal is when it's infected. Otherwise, generally speaking, you can leave this dead skin, or someone's got a cavity in the ear canal, so either a crater at the base of the ear canal or a mastoid cavity where the ear canal has the mastoid bone on the posterior part of the ear canal has been drilled out due to an infection. Because what happens then, skin can, as it dies and sheds from the eardrum outwards towards the entrance of the ear, if you've got a cave or a crater or a cavity, this skin can collect and it can then get infected. So that's another occasion really where a clinical need where I remove the skin. So we finished the right ear, we're just on the patient's left ear. So with this ear, and this is all keratin, it's not wax, it looks like wax but it's not, it's dead skin keratin that's shedded from the eardrum. This skin then migrates outwards like a conveyor belt, like a snake skin, but just near the entrance it's got trapped. And presumably the reason why it's got trapped is because the client's ear canal entrance is very, very narrow, and they have got a twisty entrance as well. So the ear canal entrance, the first bend is quite pronounced, and also the second bend. So all of our ear canals, you get an S-bend, and that S-bend is designed to protect the eardrum. So if you do have a foreign body that enters the ear canal, it has to migrate past two bends before it makes contact with the eardrum. So the two bends in the ear, they're there for a reason. It's an evolutionary advantage to have an S-bend ear. Some have the S-bend is more pronounced than others. And there could also be an acoustic advantage as well to have an S-bend, so sound waves can reflect off. So if you think about all the folds and creases on the outer part of the ear, the pinna, they're there for a reason. They attenuate certain frequencies and they amplify others. Typically the folds and creases on the outer part of the ear canal, they tend to amplify high frequency sounds. and that enables us to have what we call front-back localization. So sounds that arrive in front of you, they get amplified by the folds and creases on the outer part of the ear. We hear them louder. And if you've got high frequency sounds coming from behind you, they don't get amplified by those folds and creases because the sound's coming from behind. So sometimes when you see people cut their ears forwards, it actually does, you can try it yourself, it does actually amplify, it boosts the high frequency sounds. So there is a reason for all things in the ears, there's always a reason. And therefore I also suspect there might be an acoustic advantage of having an S-bend. I'm not sure, I'm going to read some more literature about that, but I know certainly there's a protective measure to protect the eardrum. So the left side is a lot more tedious. The skin, I wanted to remove it because, as I said, it's just going to come back for the patient. Even if I can give them an extra month relief, it's important. So on the back part of the ear canal, using a fine end gauge attached to a standard suction probe. And this is not really possible with some of the other visualization techniques. I saw another technique today, recording it. I was quite shocked actually how poor it was. There's no way I would be comfortable doing this other than with an endoscope or an operating microscope. But the advantage of the endoscope is the field of view. It's just uncomparable. Not only am I peeling this dead skin off the canal wall, I'm really near the eardrum here, but I'm also able to see the ear canal, so I can navigate the fine end. I can think, okay, well, I'm peeling it here, I want to peel it off here as well. It gives me more manoeuvrability, more agility, the endoscope. Yes, a bit of a skill, as a lot of our delegates find, but it just takes practice, and you need to be trained properly. This is not something that you can just pick up. We often get inquiries from people who perform earwax removal using head loops or microscope. Oh yes, just send me the endoscope, I'll be fine. I think that's really bad. Okay, if you're an ENT specialist who uses endoscopes already, fine, I totally get that. I'm not going to teach an ENT specialist who uses endoscopes already how to suck eggs. But having said that, we've had a few ENT specialists come on the course. Even one of our old directors, Darius Rajali, one of our co-founders, he'd be the first to admit, yes, there's a different skill using a rigid endoscope in a patient who's awake. So typically, so Mr Rajali, this is his own analysis really. When you're performing endoscopic ear surgery, the patient's asleep, typically, if you're using GA. So there's a bit of a knack in this, and so if an ENT doctor has got the humility themselves, like Mr Rajali, to admit, yes, there is a bit of a learning curve even for him, then sometimes it does infuriate me when I hear fellow audiologists or hearing aid dispensers who feel that they can just pick this up. Now, obviously at Clearwax, it's a medical device. We have a disclaimer. We always say to people, we recommend you do get trained in this, but yeah, I wouldn't want to be one of their patients actually, if I'm truth be told. If someone's just picking this up and thinks they can use it and figure it out themselves, I don't think that's I think that's almost clinical negligence. So yes, there's a bit of a learning curve, and that's why we train people. But once you're trained, and if you've got the required skill level, there's no better technique. So we're just on the anterior canal wall. This is the front part of the ear canal. And again, the skin, it's very tightly adhered, so that's why you can't always remove it. So the skin is dead, it's a dead layer of skin, and this skin is trying to come out naturally. It's migrating sideways. But yes, it's very tightly adhered. Just want to give a quick shout out to one of the subscribers. They've been messaging me quite regularly, making comments that they don't enjoy my commentary, asking me not to narrate. So these are educational videos, guys, and some people prefer not to listen to the audio. That's totally fine, totally understand that. But for those that do, obviously I'm going to continue to narrate. If you just rather watch the procedure, you can actually just mute the sound or reduce the volume. I forgot to just I will give them a personal shout out because they've been quite vocal recently, and it's actually my fellow friends who have picked it up. It's Jennifer L. Void. So hi there. Thanks for your messages. So nearly done. As I said, there's a bit of keratin just at the entrance here. There's a bit more medially. I don't recollect. I can't remember if I managed to get that piece of skin a bit more medial. I think I might have left that. We'll see in a moment. Oh, I'm going back for it. So I'm pretty sure I don't get all of it because it is very stubborn. It's very tightly adhered. But I'm happy with what I've done. I've removed as much dead skin keratin as safely as well. When you peel keratin, it can also clarinet. Clarinet is a high frequency whistling noise that occurs because this keratin flaps violently at the tip of the endoscope. Not the endoscope, the suction probe. A fine end is great though, it really reduces that clarineting, and this patient fortunately didn't get any clarineting. It's just some soft mushy keratin just at the entrance here, just at the base, literally just at the entrance. So you can see how bendy the ear canal is. You can't see the eardrum there. I'm just looking straight into the ear canal with the endoscope and I'm seeing the back part of the ear canal. So this first, I think this is the second bend actually, the second bend you can see there. It's almost 45 degrees, I would say. So it's a very prominent bend. But with an endoscope, if you've got the correct skill, you're able to mitigate that and work around corners and bends. Yeah, it's very pronounced actually. I didn't realise how bendy the ear was. So this is the second bend where the suction probe is, and I just touched that. That's the second bend. And that's the tympanic membrane. Look at that view. I still kind of sometimes taken aback by the view with an endoscope. I did a lot of my training with an otoscope. And when I first realised and looked through an endoscope, it literally changed my career, if I'm honest. Yeah. So I hope you enjoyed that video, guys, and you're all having a great evening or morning or afternoon, depending upon where in the world you're watching it. Take care, bye.